Good morning, everyone. Grand welcome to my YouTube channel. Today we are going to discuss about influenza virus. As you all know, influenza virus cause the wide spectrum of diseases from the seasonal flu to the deadliest H1N1 pneumonia. Ladies and gentlemen, I am Dr. Zakir Hussain, a pulmonologist and critical care specialist at Bahrain Specialist Hospital in Bahrain, in the Middle East. Today we are going to discuss about the structure of this virus. The influenza virus comes under the group of Orthomyxoviridae, and there are multiple viruses available in influenza A, B and C. We commonly talk about influenza A and B because it affects human beings a lot. And if you see the structure, it is same like COVID structure, COVID-19 virus structure with the contents of 8 single-stranded RNA segments in this genome, which is covered by the capsid layer. This entire virus is around 50 to 100 nanometer in diameter and contains certain spikes on the top of this one. The spikes commonly seen are N spike and H spikes, the neuraminidase spike and the hemagglutinin spikes. The influenza viruses are in influenza A, it is has multiple types from H1 to H18 and N1 to N11. Whereas in human beings, we see H1 and H2 are the commonest strains that affect humans, and whereas in N strain, N1 to N5. Whereas in influenza B, we see Yamagata and Victoria strains are very commonly affecting human beings. If we can see the structure of this virion, it contains these spikes H and N spikes, and the hemagglutinin spike goes and attaches to the sialic acid membrane of the host epithelial cells, and by that it helps in binding, and thus the cell enters into the RBCs of these cells and cause agglutination of RBCs. That's why it's known as hemagglutinin. And once it replicate inside and it form multiple virions, and by the help of neuraminidase, the N spike, which helps in cleaving these receptors out and releasing new virions. That's why the Tamiflu, the neuraminidase inhibitors, which will block these receptors and prevent the replication of these virions. That's why we had to start oseltamivir, which is commonly known as Tamiflu or Fluvir. We had to give early, within 48 hours, to see good improvement, good outcome from the patients. After 4 days, there is no role of giving oseltamivir. So give early. And these viruses replicate and cause multiple pandemics and epidemics by having this drifting and shifting in the viral genome. So what is antigenic drift? If you can see here, there will be multiple minor changes in H and N genes mutations causing changes in the protein antigenicity. If you can see here, the circles and the triangles and the spikes here, which will go under mutations and cause this kind of different structure. Unfortunately, the antibodies that were formed by the previous viral infection and also previous and the because of the vaccination that we get, the antibodies produced will not recognize this new virus B. That is the reason they will cause multiple infections, and which will leads to multiple epidemics in many countries. So that's the reason every year we have to get a new update of vaccine. That's why this vaccine has to be taken yearly. And this virus will shift into causing more dangerous, deadliest virus. The antigenic shift means there will be major gene mutations in H and N genes, which will cause to emergence of the completely new influenza virus, which is antigenically and genetically. Both ways is different from the viruses previously circulating in human beings. It happens over the years, and the changes happen slowly. So influenza A is more commonly causing antigenic shifts. That is the reason we do see pandemics commonly because of influenza A than influenza B. And if you can see here in this slide, there are multiple pandemics occur all over the world. The first most deadliest pandemic that everyone knows are in 18 and 19 Spanish flu, and then followed by the Southeast Asian H2N2, and the latest one 2009 and 2010 that all we all have seen this one H1N1 pandemic. This has come from the swine or pigs. From that the flu has originated to the human beings. That's why it's known as the swine flu. If you can see this historical picture, this is known as the Spanish flu. This happened in 1918 and 1919. Why it is known as Spanish flu? It has occurred in almost all over the world, but the Spain being a neutral country which has published a lot of data regarding this media in the Spain, they have published a lot of data compared to other countries like our current media. They're not publishing any data. Even the governments are also not declaring the data of the disease and also mortality because of the World War One that was going on. This Spanish flu is known as mother of all pandemics because it has affected one third of the world population and has taken almost 50 million deaths. And the peculiarity of this virus, Spanish flu, compared to other pandemics that happen all over the world till date, is almost young individuals from 20 to 40 years. If you can see in these images, these almost everybody were soldiers in the World War One. So the death among these young individuals was the most peculiarity. One of the explanation hypothesis was that the 40 years back they had the similar flu, H1N1 flu happened there from the Russian flu. That the people who got exposed 40 years back were protected, and whereas the people who haven't got exposed at that time got affected badly. So that is the reason we see soldiers died a lot in this world war, in this pandemic compared to the world wars. And the death is commonly because of these viral pneumonias going into secondary bacterial infections, leading to purulent bronchitis, and they leading to further hypoxia, which has caused heliotropic cyanosis. This was from there the mortality happened. Unfortunately, that was a pre-antibiotic era, so they don't have antibiotics in the First World War. That's why it has taken a lot of deaths. And this influenza, let's discuss about the disease. It's a self-limiting disease with an incubation period of 1 to 4 days, and usually fever occurs from day 1 to day 3 to day 5, and the recovery, complete recovery, we see in 7 to 10 days in most of the patients from influenza, and it spreads by the respiratory by the droplets, and the droplets will sometimes are deposited on the doorknobs, on the tables, on the shirt. From there, the fomite transformation is also more common, and unlikely to swine flu and unlikely to the COVID pneumonia, COVID virus, this simple mask is sufficient. Whereas the symptoms are similar to the COVID-like infection, all the viruses same, like if it enters a group of 4 people in the house, each person has different symptoms, depends on their immune response to the viruses. So most of the viruses cause early malaise, the feeling low, and headaches. These are the first common symptoms seen in most of the patients. And second comes the fever. Depends on the person. So there will be mild, moderate, and to high grade fevers. And some people do find chills also with these viral infections. And runny nose, stuffy nose are very common, like all the flu. And sore throat also starts badly in this influenza, especially last 6 months. We are seeing a lot of people coming with severe sore throat and cough, with the lingering cough up to 10 to 15 days. We are seen with these new viruses, new influenza strain, especially the H3N2 that happened last 6 months all over the world. And the muscle and body aches also very commonly seen, and fatigue, the tiresome, because of the dehydration, because of the viral illness, there will be significant fatigue, and post-viral fatigue also seen very commonly from younger to the old age population. Strangely, this influenza virus, this time we have seen a lot of people coming with the G symptoms like vomiting and diarrhea. And we do see a lot of people have other symptoms also. The diagnosis is same like COVID is a rapid influenza diagnostic test. The same nasopharyngeal swab or nasal swab is sufficient to diagnose this one. This is a rapid antigen test, same like rat test. And another option is rapid molecular assay, which has better sensitivity and specificity compared to the rapid antigen tests. And the gold standard is RT-PCR. Same like COVID, RT-PCR is gold standard even in influenza. The RT-PCR helps us in identifying the subtypes of the influenza like H1N1, H3N2 compared to the rapid molecular assays. And the multiplex molecular assay like BioFire and all those things helps in differentiating multiple different viruses with the bacteria to identify the bug early. But it's a little expensive. Not all the H1N, not all this viral influenza leads to severe ARDS, but we do see a lot of people with low immunity goes to this much of severe pneumonia. If you can see the complete whiteout of the lungs, may happen, leads to ARDS like picture. These are the CT scan of the similar. We can see only 10% of the lung was functioning here and 10 to 15% of the lung was functioning here. The treatment for ARDS, as you know, ARDS is defined by mild, moderate, severe, depends on the PF ratio, PaO2 by FiO2 ratios. For every patient, first airway, secure the airway properly, and breathing request starts from nasal prongs to the face mask to the high concentration mask. If they are not doing well, then the first thing is non-invasive ventilation and HFNC. Especially immunocompromised people, even in the moderate to severe ARDS also, we had to think about going with non-invasive ventilation because ventilator-associated pneumonia in these people has high mortality. Whereas in other population, from moderate to severe, we had to go with early mechanical ventilation. And with the with the ERDS net protocol, the lung productive ventilation, low tidal volumes, and high PEEP. And the only thing that proven mortality benefits are proning. Early proning of this patient with the mild to moderate ARDS helps a lot in preventing further worsening of these patients. And in ARDS, still these steroids are always controversial to prevent the fibrotic phase, early onset, early initiation of steroids. But in influenza, you should be very careful because steroids may worsen their condition. Whereas in COVID, there was a strong suggestion for going with steroids, but still in influenza, you should be very cautious in starting steroids because this will worsen the patient's outcome also. Who are the people who are at high risk of getting influenza complications, like especially elderly people more than 65 years of age and children less than 2 years and people with multiple comorbidities like asthma, COPDs, heart diseases, sickle cell diseases, kidney liver failures. All these patients are more prone to get disease, especially pregnant ladies in third trimester and also up to 2 weeks postpartum. They are more prone to get this bad influenza complications. One of the striking thing is most of the people think influenza is a respiratory thing only, but unfortunately it has a domino, we call this domino effect of influenza. This infection triggers various effects that can exacerbate underlying chronic medical conditions like underlying cirrhosis of liver or underlying cardiovascular disease. It will further worsen those diseases leading to other common complications, leading to high risk of hospitalization and high risk of death among the patients. So this is the fascinating study that I found, the hidden burden of influenza, review of extrapulmonary complications of influenza infection. This is published in 2017 by the Pulmonary and Critical Care Group and ID specialist, and which has good details about extrapulmonary complications. The others, some of the commonest complications that we see, the cardiac complications are same like COVID. We do see a lot of people do develop viral, post-viral myocarditis, post-viral MI, and worsening of baseline coronary artery diseases. And we do see a lot of patients getting arrhythmias and also worsening in their heart valve diseases and heart worsening in their baseline heart failures. And uh, we have come across a lot of cases of pericardial effusions also post-viral, but thin rim of pericardial effusion, not like significant, which subside with simple colchicine and other supportive care. And next common neuro complications are post-viral encephalitis and encephalopathies are very common, especially we do see in elderly people. And Guillain-Barré syndrome we come to see very rarely, but it happens post-influenza a lot. And worsening in their stroke, worsening in the seizures, all these things are very common complications in neuro patients. And common hematological things we see in the CBC in patients with the viral infections are leukopenia and lymphopenia and thrombocytopenia. Mild thrombocytopenia, we do see a lot of people. Even after recovery also, we see post-viral reactionary lymphocytosis for almost like up to 1 month, and reactionary post-viral thrombocytosis also seen in most of the patients. Same like COVID, influenza is also unfortunately prothrombotic and leads to clots and blood clots and embolism, pulmonary increased instance of DVT and pulmonary embolism. And hemophagocytic syndromes also commonly seen, and TTP-HUS also we can say post-influenza. And viral conjunctivitis also very commonly seen. I think last 6 months in India, we have seen a lot of cases of viral conjunctivitis. Especially adenovirus is more notorious to cause viral conjunctivitis with respiratory, whereas influenza also has caused a lot of viral conjunctivitis in most of the patients. And worsening in the renal baseline conditions also, because of the fever, high-grade fevers and dehydration, uh, causing new AKIs or worsening in acute on CKD. Also, we do see a lot of patients have coming with those complaints. Especially last 3 months, we have seen a lot of patients coming with the GE side effects, GE symptoms of influenza, like diarrhea and vomitings and abdomen pains. By incidentally, by admission time, if you do the swab test, they have come with influenza A positive. With the lesser respiratory symptoms, more of diarrhea, we have seen a lot of patients. And same like other organs also, we have seen influenza has worsened the underlying baseline liver diseases and also causes common transaminitis like other viral infections. And diabetes mellitus also new onset and also worsening in the diabetic control, leading to decay and HHS. And some people do come with post-viral thyrotoxicosis, commonly decurrence thyrotoxicosis, and myopathies and other symptoms are very common. Especially in respiratory, in obese people, we have seen worsening in the sleep apnea in lot of patients. Let's discuss about the treatment of influenza. The only proven treatment for influenza is antiviral agents. The first common more potent antiviral agents are neuroimmunidase inhibitors, which will help in treating influenza A and B. And the mechanism action is it interfere with the release of progeny influenza virus from the infected cell. I think I have shown in the initial slides. It will prevent the replication, but early starting of these neuraminidase inhibitors or the treatment, there's a basis in this. You have to start within 48 hours of the symptoms. After 4 days of the influenza symptoms, there is no role of giving antivirals. The common things that we see is oseltamivir, zanamivir, and peramivir. Peramivir is expensive IV drug, but it's not available most of the countries. Whereas oseltamivir is mostly seen from last 10-15 years, we are seeing that one. And second group is endonuclease inhibitors. The selective inhibitors of influenza cap dependent endonuclease is the mechanism of action. Baloxavir is the commonest drug. is the only drug that available, and is same like neuraminidase inhibitors acts on influenza A and B. Adamantines are the effective only influenza A. These are the old drugs. Nowadays, we are seeing a lot of resistance for H1N1, so we are not using amantadine and rimantadine. These are commonly used as anti-Parkinsonism drugs also nowadays. Let's discuss in detail about the oseltamivir. There are so many studies that have shown that this oseltamivir has helped in shortening the symptoms by 24 hours, and it has shown reduction in duration of the viral shedding and also reduction in the severity of the illness with the decrease in complication rates and the hospital admission rates. And also it has reduced the length of hospital stay in most of the patients, and it comes in oral form and syrup, oral form only, both as a tablets and syrups. The Tamiflu is one of the commonest brand, and also Fluvir and other brands are also available in many countries. The 75 milligram twice daily is the adult dose as a therapeutic, whereas the preventive and prophylaxis dose is 75 milligram once a day. It is very effective in A and B. The common side effects that we come across from oseltamivir are nausea and vomiting and severe gastritis in most of the people. That's why we advise them to take after food, or preferably, as we always misuse the PPS, adding PPS will always help in giving the patients with oseltamivir. And delirium in children is very commonly seen with oseltamivir. It's one of the landmark study that has this is a meta-analysis of almost 10 studies with 4 RCTs and 6 observational studies. They have proven that double dose versus standard 75 milligram dose for influenza. In last 5 years back, 10 years back, we used to treat with 150 milligram twice daily dose for the ventilator patient with severe ARDS. But this study has shown that the doubling dose of oseltamivir was not associated with any decrease in mortality in patients with influenza, and also doesn't show any statistical benefit of virological clearance rate, and also incidence of adverse rates. So it's of no point in giving 150 milligram twice daily for the patient on ventilator or severe influenza symptoms. 75 milligram twice daily is more than sufficient for patients with this thing. Another good study that I have found is this cocktail therapy of clarithromycin and naproxen 1 NSAID and oseltamivir combination therapy versus monotherapy with oseltamivir alone in hospitalized pediatric influenza patients. This study published in 2021 has shown that there's a good improvement in patients, and also the cocktail group, the combination of this clarithromycin, NSAIDs and oseltamivir group experienced a more rapid difference within 14 hours compared to 36 hours in oseltamivir monotherapy, and a more rapid decline in influenza virus titers than the group treated with monotherapy of oseltamivir. And fortunately, there was no difference in adverse effects such as severe gastric symptoms, because clarithromycin will cause severe gastritis, and also NSAIDs and also oseltamivir. All these things are notorious to cause gastric things, but this cocktail therapy hasn't shown any significant difference with monotherapy in adverse effects. So you can better give a trial in patients with comorbidities going with the cocktail therapy. I personally saw good benefits by using this cocktail therapy. The second neuraminidase inhibitor is zanamivir. Unfortunately, it is not available in many countries. This comes as an inhaled form, 10 milligram twice daily. This comes as a 5 milligram capsules only, which we have to inhale with the discus, and similar, which has similar efficacy with the oseltamivir, and it also reduces in duration of the symptoms and equal efficacy compared to the oral oseltamivir. This is used in patients with oseltamivir resistance. Nowadays, we are seeing a lot of people coming with oseltamivir resistance because the lot of misuse of oseltamivir whenever there is a simple epidemic goes on. And the only adverse effects we see with these inhalers are bronchospasm. Unfortunately, we can't use these in hospitalized patients, and unfortunately, we can't use it with asthma and COPD patients because of the bronchospasm. So only oral one is better option. And as you all know, prevention is better than cure. So flu vaccine is always safe, and the common indications for flu vaccine are all children from 6 months to 5 years, and all adults without comorbidities more than 50 years, and adults with any age group with the asthma or certain cardiac diseases, renal and other comorbidities, they are always advisable to go for a vaccination. And all immunocompromised patients, especially pregnant ladies, we have to vaccinate, and the BMI and obese people also we have to vaccinate with the influenza virus vaccine. And this the influenza compared to all other adult vaccination, influenza vaccination is well studied. This is the this is published in 2017. This article has shown that significant reduction in odds in hospital death among elderly in all age groups from 18 to 50 years and 50 to 64 and more than 64. Everywhere they have shown that there is a mortality benefits, reduction in hospital deaths, and also reduced ICU admission among the all age groups with the shortened ICU length of stay in people with elderly with comorbidities, and also length of reduction in length of hospital stay also shown significantly less in people vaccinated compared to non-vaccinated individuals. The types of vaccines that are available nowadays in 2023 are inactivated influenza vaccines and recombinant influenza vaccine and live attenuated influenza vaccines. So this is the common, I'm not branding anything. This is the common thing, the quadrivalent vaccines that are available. Previously, we used to have trivalent vaccines. From last 4 years, WHO is strongly suggesting to go with quadrivalent vaccine, which contains additional influenza B Yamagata strain. Other three strains are influenza A, H1N1, and H3N2 are commonly seen in all vaccines, and Victoria strain from the B, influenza B, will be there even in trivalent also. Whereas quadrivalent, they added extra Yamagata strain. And the one peculiar thing about these vaccines are, if you can see, the dose is only 0.5 ml dose, which contains only 15 microgram of hemagglutinin of H1N1, H3N2, and influenza A and influenza B, both Yamagata and Victoria strain. And these are propagated in the eggs only. This is the common vaccine that we available. So I kept this photograph of it. Whereas now WHO and CDC has strongly recommending elderly people because they mount poor response from the vaccination because of their poor immunity. So less immune response because so they need higher dose of vaccines. People above 60 years and 65 years, they need 0.7 ml compared to 0.5 ml that has shown previously, which contains only 60 micrograms. 15 or 4 strains are 60, whereas here it is 60 microgram, 4 times that dose than that one. So it is strongly advisable in almost all elderly people and people with immunocompromised also because of the poor response to the vaccine. These are the common vaccines recommended in those people. High dose quadrivalent inactivated flu vaccine. If it is not available, plan for quadrivalent recombinant flu vaccines or quadrivalent adjuvanted inactivated flu vaccine. Especially in pregnant women, flu is very bad. We see mortality is very high in pregnant, especially second and third trimester, because of changes on immune and heart and lung functions during the third trimester of pregnancy. Flu vaccine is safer in all trimester of pregnancy, even in the first trimester, but preferable to give in second and third trimester of pregnancy because it helps to protect their infants for the first few months after birth. First 6 months in kids, in infants, we can't give vaccination. So if we give in second and third month, we will get better immunity in those kids also. Up to 6 months, they are protected. After 6 months, we can give in those people also. And this live vaccine is the only vaccine, live vaccine is nasal one which is available, and indications are from 2 to 14-year-old and non-pregnant people only. And especially there are so many contraindications for live vaccine, the nasal vaccine, which is only indicated in people with needle phobia. Otherwise, there is no point in going with a simple nasal live vaccine with multiple complications and also is contraindicated in children less than 2 years and adult more than 50, and pregnancy is strictly contraindication, and history of any asthma, those people is contraindicated. And even now, the CDC has suggested that people with severe egg allergy, previously it was a contraindication for the flu vaccine. Nowadays, they say that clearly even people with egg allergies can receive any license recommended age appropriate vaccines. And if people with severe urticaria requiring adrenaline injection for the allergy can still go with vaccinated under proper supervision, where they can manage these kind of urticaria and other allergic reactions. Or if they don't want to go with this egg allergic vaccine, they can plan with egg-free vaccines like quadrivalent recombinant vaccine or cell-based quadrivalent vaccines. CDC strongly recommends that all healthcare professionals should be vaccinated against influenza because of multiple reasons, to reduce our patients catching influenza from the healthcare professionals. So all healthcare professionals should be vaccinated, and also to protect the healthcare professional and their families against the influenza, and also to prevent the absenteeism from the workplace whenever there is a epidemics going on. It's not too late, so plan to get vaccination as soon as possible. Thank you for your patience listening. Please subscribe to my channel. I will be coming with more videos. Thank you for your patient listening.